this proposal does not go into effect for 48 months. So essentially, we'd have about a year of operating this program before we would have to be beginning to operate something under the Affordable Care Act. And one of the things that we do know about this proposal that is not in keeping with the Affordable Care Act is that the Affordable Care Act says that people will not have out-of-pocket costs at 400% of poverty of over 10% of their income. And I'm not going to offer my amendment today because you haven't been willing to accept it, so I know that it wouldn't be adopted here today. But at 275% of poverty, clearly the Affordable Care Act would require out-of-pocket that would be far less than 10%. I think we could probably agree on that. So I don't think that this is a good transition to whatever the federal government is going to have for people through an exchange. I also think it's important for people to read the fiscal note. And the fiscal note says that that this benefit is 40% less than the benefit we have in Minnesota Care today. And that is even with the hospital benefit that we have in Minnesota Care today that I think everybody could agree needs to be improved. 40% less. So that means that the participants are going to have to pay 40% more out of pocket. Whether it's through a deductible or a copay or however it happens, they're going to have to pay 40% more out of pocket. And I don't believe that's affordable for the people that are in this program. And so that means that if it's not a hospital that's having trouble collecting from somebody, it'll be a clinic or a pharmacy or some other healthcare provider that is trying to provide services that isn't going to be able to get paid because this person can't afford to pay them. The fiscal note also indicates that there would be a 10% drop in coverage, which stands to reason since probably about half of these people are going to be denied coverage through an insurance agent and are going to have to try to apply to MSHA. And the harder you make it for people, the more hoops they have to go through, the more drop-off you get. And so there will be some people that when they're denied coverage the first time will not go through the process of looking for other coverage and will just assume they got turned down. I think these are all things in the bill that are troubling to me, and I hope they'll be troubling to the other members of this committee, and so I don't plan to support this bill today.
Senator Hann.
Thank you, Madam Chair, and thank you, Senator Berglund, for your comments. And let me try to respond to a couple of the things you mentioned. I think we probably are going to end up disagreeing about the virtues and perhaps even the likelihood of the federal health care structure being implemented as it is designed today. I'm more of a skeptic about that. You may be more of an optimist about that. But we won't know for a while what is going to be the future of that federal plan. I believe that we should, for lots of reasons, all hope that it doesn't happen. I think that from my perspective, we want to try to have the maximum amount of flexibility and the ability to make decisions about health care here in Minnesota. And you know probably more than anyone the kinds of constraints that the federal requirements put on our ability to do things in Minnesota that we may think are of value that make it that we cannot do because of the constraints the federal government has on the current structure. And I see that the proposed expansion would carry us further down that path of tying our hands and driving up costs because of the lack of ability for us to make changes that we think would make financial sense. So I'm not trying to essentially structure the bill to accommodate a future event that may or may not occur. As I said, I'm hoping that it doesn't occur. I think there's good reason to believe that it won't happen, at least as it's talked about today. But in my opinion, we would certainly have time between now and 2014, if that eventuality does occur, to make adjustments to the plan we're proposing to try to meet whatever constraints that are developed at that point. You mentioned the fiscal note, that there are expectations characterization that there's less benefits, and all I would say is I don't know that that is to suggest that every single person covered under Minnesota Care is going to take the exact same benefits. Those benefits may be provided, and for the purposes of a fiscal note, they're going to be costed out, but I don't know that it's a fair assumption to say that everybody's going to use those things, that people have different health care needs. But what I do know is that when you put into place into a plan a requirement that certain things be covered, there is a cost to do that coverage. And if a person doesn't really need that coverage, they still end up paying for it. And it's one of the things that drives cost in the current structure. And so you could say, well, we don't have a defined benefit structure in the plan. That is correct. And Minnesota Care does. And so you're going to say, well, the Minnesota Care plan has got some benefits and you can cost those out, and this plan doesn't do that. That's right. We don't define those benefits. But I'm not going to make the assumption that every person that is covered is going to need all those benefits, and so therefore they may not need to pay for all those benefits. And I think that's one of the things, the flexibility that this plan offers that Minnesota Care may not. And you're right, there is assumptions in the bill to say that there's an expectation that some people will not be successful in getting through an underwriting process. That does currently would require that they end up into the Minnesota Comprehensive Health Association plan. There is provision in the bill to fund that at a higher level if that were to happen. We are also working by the way here, on a bill to try to reform the MCHA structure that would, we hope, make it easier for that transition to occur. But I don't know that I would presume that if a person is denied coverage through underwriting that they would then say, well, I don't want any coverage at all. I'm not sure that that's the case. And I know for purposes of a fiscal note, assumptions have to be made. I believe that they are conservative, to Senator Magnus's point. I believe that there's every incentive that people would have to get some coverage. We're trying to provide a structure to facilitate that. But I understand your point, and I guess I'd like to continue to work with you on this. And hopefully if we do see this situation with the federal government imposing things on us, that we can find some ways to accommodate that going forward.
Madam Chair?
Senator Berglund.
Madam Chair, Senator Hann, I don't think that you answered the question that I have about, your concern that hospitals have unreimbursed expenses. What about the other providers in your bill that will have unreimbursed expenses? Because people won't be able to afford to pay the deductible or the copay that, under the fiscal note equals about 40% of what the benefits are today.
Senator Hann.
Madam Chair and Senator Berglund, again, there are assumptions that are made. I'm not sure that I accept the point or the assumption that everybody who is going to be paying out of pocket will not be able to pay those things out of pocket. I think that does happen today. I understand that. I think it happens today even under some of the deductibles that Minnesota Care requires that people pay. So I understand that there are people who will not pay the costs that they're supposed to pay. I'm not sure that my bill or any bill can totally solve that problem. But again, what we are trying to do is recognize that the significant costs to providers are the upper end costs, and that this is a program that does cover those. And we believe that on balance that there will be a higher degree of reimbursement for costs than under this plan than under Minnesota Care. But